I'd like to welcome everybody. My name's Julia Newton. I'm Medical Director at the Health Innovation North East North Cumbria, and I'm welcoming you to this webinar that's being delivered in collaboration with our NIHR ARC in North East North Cumbria. And for those of you that were with us a year ago, we did a very similar webinar talking about a project that we were about to embark on with colleagues from the public health team and local authority in Middlesbrough. And I'm delighted that we're back here today to give you a follow-up about the outcomes of that project. And I'm also delighted that we're joined by members of the local communities in Middlesbrough. So some of the community leaders and some of the commissioners from Middlesbrough who will come together as a panel towards the end of this hour. So this is what we're going through. As I've mentioned, we're going to start off with some background, sort of just to repeat some of what we went through last year with a recap of the principles of behavioural insights from colleagues from the ARC, Hayley and Liam, who I'm very grateful to them, again, spending the time with us. Joe is then going to do a quick recap of the background to the project and talk through some of the results and what we actually did. And then we're going to have a panel session with community leaders and then finish with a short film and a short question session. The film captures, again, some of the thoughts from the community down in Middlesbrough. Next slide, please. So, as I said, handing now over to Hayley and Liam, who are going to give us a quick run through the principles of behavioural insights. So over to you guys.
Thanks, Julia. So as just been mentioned, my name's Hayley Alderson and my colleague Liam Spencer will be speaking in a few moments. We're both based at Newcastle University and have done a couple of projects that use behavioural insights within them. So we'll just spend a few minutes talking to you or introducing what a behavioural insight is and specifically the EAST framework. Next slide, please.
Thank you. So yes, as Hayley said, we just want to give you a brief overview and perhaps for some of you who attended last year, as Julia said, a little recap. Behavioural insights have been used across various public services, local authorities in order to generate low-cost interventions to improve service outcomes and to improve health outcomes for the population. So the idea behind behavioural insights is that they encourage people to make better choices for themselves and for their communities. And a lot of work has been done in recent years around behavioural insights, and there's an awful lot of resources, guidance, examples available online, particularly from the Behavioural Insights team and also from the local government association. So there's a couple of addresses there where you can find lots of information if it's something you're looking to do yourself in the future. Next slide, please. Thank you. So the EAST framework was developed by the Behavioural Insights team from over a decade ago now. And the idea behind it is it provides a framework for us to encourage behaviour, to bring about behaviour change, breaking it down so that it's more likely that those things that you want to happen will occur. So it's broken down into easy, attractive, social and timely, and those are the four components of the framework that we're going to recap for you today. The idea being that if you use this framework, implement it as part of your work, then it should lead to services that are easier, more acceptable for the population, and also more effective and cost effective too. Next slide, please.
So the first principle that we're going to be looking at is about making it easy. So I guess that most people on this call have been in a situation where you've got every intention of doing something, but you've not quite got around to doing it. And this can be something really simple like switching an energy supplier to get a better deal. So bearing this concept in mind, the first behavioural insight principle is to consider how to make it easier for somebody to actually go out and do something. And there's a number of kind of subheadings to this. So the first one is about harnessing the power of default. So as individuals, we have a strong tendency to go with a default or a preset option, as this is the easiest thing to do. So if you make an option the default, it's more likely to be adopted. And this can be seen in examples such as automatically being enrolled into a pension scheme, of which you can choose to opt out of, but they're much more likely to end up staying in a pension plan than if somebody's got to actively opt in. There's also a concept of reducing what's classed as a hassle factor of taking up a service. So again, the effort that's required to perform an action often puts people off. Therefore, if anything can be done with an intervention that reduces the effort required, this can increase the uptake or the response rate. And the final thing is about simplifying messages. So making a message really clear often results in significant increases in response rates to communications. This is particularly useful if an idea is quite complex, or a goal can be quite complex if it's broken down into simpler or easier options. And an example of this would be, for instance, when they introduced the goal of eating more healthily, and that's actually broken down into the simpler task of eating 5 a day. Next slide, please.
Thank you. So the second principle is about making it attractive. So we're more likely to do something, take notice of something, or make a change if our attention is drawn towards it, if it attracts our attention. Ways of doing this can include using images, colours, or personalising what it is that we're trying to get across. An example of this could be on food products, where we now have colour-coded system to draw our attention to particular content within food. So, you know, we instinctively know that if something's red, then, you know, that might indicate that it has a particularly high fat content. And, you know, we know that green things are perhaps more healthy for us. That's a really simple way of attracting our attention and making something attractive and easy for us to understand, as Hayley mentioned before. Also designing rewards and sanctions for maximum effect. So particularly in research, we know that financial incentives are often highly effective to encourage people to participate in our work. So we might offer chances for people to win a £50 voucher if they take part in our research. And, you know, especially in the climate where budgets are quite tight, this might be easier for us, more cost effective than offering a £10 voucher, say, for everybody who takes part. But it still makes the option of taking part quite attractive for people who are considering it. Next slide, please.
So the third principle is about make it social. So as human beings, it's kind of often evidence that we're heavily influenced by what other people around us are doing and saying. So if you can do something that shows that most people are performing in a desired way or having a desired behaviour, this will encourage others to do the same. We also kind of know that it's really useful to use the power of networks. So as individuals, we're normally embedded in a network of social relationships. And it's known that those we come into contact with will shape our actions. So networks can be used to enable collective action, provide mutual support and encourage behaviours to spread from one peer to another. An example of this would be something such as TripAdvisor, within which people are more likely to stay somewhere that has received higher ratings and good reviews from other individuals, as opposed to somewhere that has received negative reviews. Another factor that is shown to be effective is encouraging people to make a commitment to others. So we often use commitment devices to voluntarily lock ourselves into doing something. And this is proven to be the easiest way to almost raise the stakes. So if you make your commitment in public or to another person, so ideally somebody who you respect or value the opinion of, there's more of an obligation to follow through on commitments, and this can be seen in a number of different behaviour change activities. Next slide, please.
Thank you. So the final principle is about making it timely. So it's really important that we prompt people when they are most likely to be receptive. So the same offer made at different times can have drastically different levels of success. We're more likely to change people's habits during periods of transition, which disrupt and reshape kind of normal patterns. For example, when somebody finds out that they're pregnant, that's often a very good opportunity to look into stopping smoking. We also have to consider the immediate costs and benefits. So we are more influenced by costs and benefits that take effect immediately rather than those that are delivered later. An example of that being eating unhealthy food that's tasty. You know, we get the benefits up front, but there are costs longer term. and also helping people to plan their response to events. So there is a big gap between intentions and actual behaviour. So we know that making a plan means that people are more likely to achieve a future goal. For example, within drug and alcohol use services, setting goals, thinking ahead, highlighting common barriers to achieving them, and showing people plans that others have used in order to overcome these barriers. Next slide, please.
So the final bit that Liam and I are going to touch upon is about how you implement this approach in practice. So the first part of it, as you can see, there's kind of 4 stages to this process, but as you would expect, the first part is understanding the problem or defining the outcome. So it's really important to identify exactly what behaviour it is that you would like to influence by introducing a new intervention or a package. You also need to consider how this can be measured reliably and efficiently to actually give you a desired kind of benchmark or something to gauge progress against, and establish what change you would like to see that would make you know that the project had been worthwhile, and over what time period you would like to see the change occurring. So is it something that you would like to see a change in really quickly, or actually are you expecting that change to occur over a longer period of time? But to help you define the outcome, you're expected to understand the context. So by doing this, we would encourage people to visit the situations and people involved in the behaviour and understand the context from their perspective. You could then use this information and lived experience to design something that is sensitive and feasible to be rolled out in practice. The third part would be to kind of bring the information together and build your intervention. So within this, you could use the EAST framework to generate your behavioural insights. It's really likely that this is going to be an iterative process that actually kind of returns and moves between the steps above as well. And the next stage would be to test, learn and adapt. So actually put your intervention into practice so its effects can be reliably measured. Wherever possible, although this isn't always feasible, it's good to have a behavioural insights attempts to use a randomised controlled trial to evaluate its interventions, within which you would have a control group so that you could clearly understand what has happened if you hadn't done anything, although we do recognise that this isn't always feasible. What you will often see within projects as well is, say, a continuous movement between these different steps. But that was a real brief whistle-stop tour to behavioural insights in the EAST framework. So that's all from Liam and I for now, and we'll hand over to Joe to talk about the project in Middlesbrough. So thank you.
Thank you.
Thanks, guys. So over to Joe now, who's going to talk about the specifics of the Middlesbrough project in the context of what you've just heard about the EAST framework. Over to you, Joe.
Thanks so much, Julia, and thanks, Hayley and Liam. And I also know, and I had to make a shout out here, I've got some colleagues from abroad who are on call, so welcome those from Zambia, Lusaka, who are also academics in this field. For the interest of time, we will be sharing these slides. So some of you who are in the original seminar or webinar will have seen some of the slides that are sharing, but we will share those slides for you to get the detail. But we do want to get to the part where we do the discussions with some of the community leaders. So I'll whiz through some of these slides, and most of it actually has been nicely covered by Liam as well and Hayley. So is it moving?
Not yet.
Not yet. Yes. So I have requested control. Now it's not moving my side when I'm moving. So if you don't mind, Hayley, just move next slide for me.
It's Abby. Mm-hmm.
Oh,
Abby, can you move
sorry.
There you go. Okay.
Yeah. So this is just the context of trying to synthesize all the stuff that Hayley and Liam were talking about. So we needed to put this in a program. And our project, which we're working on, was that Innovation for Health Inequalities program. And that is the background. We wanted to address health inequalities, co-design and intervention, work on some priority areas, in this case, CVD. We had some national funding, but it was a collaborative venture. So it wasn't just the Health Innovation Network, it was all those partners in the last bullet point. Next, please. So these were aims, as Haley mentioned, that you needed to take stock of what you want to achieve. So we wanted to have more insight into barriers and challenges of why people don't take up CVD risk assessment. We then wanted to co-design potential solutions for improved uptake, then pilot that co-design solution. And as the Behavioral Insights team has just mentioned, they share those learning. On the next slide, these are the communities where we engaged. So we work with Noah Fitness, who's on the panel, with some South Asian women. We work with the community hubs to look at underserved wide population groups from deprived areas, then looked at some South Asian and African communities through Idris and his communities, and then worked with Bini around some targeted Black Africans and resettled doctors who have got an opinion around CVD health check. On the next slide, please. So again, we're sharing this slide. This is the detail of the methodology. We engaged 7 focus groups. Kindly, we were facilitated access by the community leaders, and we had 45 participants. And as I've mentioned before, South Asian, Black Africans, and underserved groups. And the detail is on those slides in terms of where we actually deliver the sessions. It was important for us to not to invite them into our settings, but to actually go and research them in their own settings. So those were these areas where we visited. On the next slide, please. And again, Haley and Liam have nicely covered this. We brought this to life using that EAST framework. And on the right is the couple of questions which we are asking for, those qualitative interviews which we held. On the next slide, please. And if you just put on a few more. So I won't go through all this. Click a few more. So this, in terms of that theme around how easy it was to access CVD health check, those are some of the responses we're getting around issues with GP appointments, language barriers, convenience, health literacy, waiting times. And again, for most of you who've worked with different population groups, these are recurring themes. The next principle was attractiveness. And again, this is mentioned by earlier speakers there. This is why it is attractive for people to access health checks. And you can see a whole multitude of issues from, staff attitudes, feelings around discrimination, but also are they taking active decision making within those consultations. The next principle is around the social element. And again, those were quotes directly which we got from participants, really coming from the heart in terms of what stops them to consider health checks. So from a social perspective, the need for behavior change was mentioned. That universal, that big word from Sayyid Mahmoud around proportionate universalism. So you need to target those people who are at highest risk. But there was elements of reflection around tokenism, whether you just go and consult people and get them involved, but you don't do what you have to deliver. But actually, real big questions were being asked to say, what is actually a health check? And we'll come to that when we discuss with the community leaders. The next principle, the last one, was around timeliness. And again, at your own leisure, when you get this slide, you can read through some of the quotes which are directly being spoken about. Cost, we know that NHS is free at this point of access, but actually for those people who go and access services, they might take 3 taxis or 2 buses. So there's a cost to service access as well. I'll move on to the next slide, which just shows you the global themes that we managed to use in that framework to tease out. And these were the themes that were important to the stakeholders we worked with. So on the next slide, please. And there's a couple of barriers that we'll share here, which were coming up from the participants. And again, this isn't rocket science. These are real things that affect those who are underserved or coming from deprived wards. So staff attitudes, health literacy, we've pointed out before. But cultural competence was a really key theme where you needed to understand the culture. How do you deliver the service? Should it be women-only service? And where should it be delivered from? But over and above the key barriers, the next slide will show you what were the opportunities. So in terms of enablers, so we were not just asking them what stops them from accessing service, but we were also asking how they would want the services to be delivered to them. So we know, and Katrina will talk about this, there's health champions in the landscape. We also know there's different interventions like social prescribing, social marketing, motivational interviewing, as well as translation service, which actually can unlock service access if people can understand what they need to access. So on the next slide, please. We had to come up to condense all this to say, what does it mean? How do we change the behavior? And again, you will have time to consume this at your own leisure. But those are the four principles that were really important around what is the capability of that individual to digest the information that you want to share? What are the opportunities in terms of the assets which are in the community or the resources that are shared with them? But actually what does motivate them, as Liam was mentioning there, you need to have a motivation. Whether you're pregnant at a point in time and you want to stop smoking, it is about having that opportunity at the right time. And ultimately, our behavior we wanted to change was accessing health checks. On the next slide, please. And again, this is just the same put in a kind of a toolkit, not just posing barriers, but also having enablers in terms of how do you capitalize on taking those opportunities. So the next slide will show you what we got from the research, which were all potential interventions. And I have to highlight all those 5 interventions were suggested by the communities we work with. We need to advertise services a lot better. We need resources to improve health checks, but also training of the workforce is quite important. But training also goes hand in hand with capacity building. So we do have resources we have mentioned, like community health champions already there, translation services, but also there's grants within communities where they can tap into. And the last one there is community outreach and social prescription. And I have to say, our project then, because it was time limited, had to focus on an aspect that is deliverable within that time scale. Then we actually then chose the community outreach element, which I'll expand on again, where we had a health bus going into communities to actually go and test the people in their own settings and improve uptake. The next slide, please. So ultimately, these were, as I've mentioned, we chose out of all those interventions, although we covered some of the stuff that they wanted to be addressed. We delivered outreach sessions, and we had about 29 health check outreach sessions delivered in different formats. You can see there's some at Teesside University and on-site delivery, but we also had the Middlesbrough Foundation bus, which had trained health champions going out to test people within the bus. And it was, because it's branded as Middlesbrough Football Club, quite a safe place for most people to frequent. Not everyone, but most people. But we also had targeted sessions which were delivered by the Health Innovation Network, as well as some of the women-only sessions, which Shazia will talk about later. We also held a debrief session, which you would see at the end some of the snippets of the videos of community leaders talking about the program. I'll whiz through the next few slides, please, so that we're on track. We were sharing this, and we've got our community leaders on board, so they will articulate some of that stuff there. The next slide, please. And again, another quote from Idris there, just talking about bringing communities together after you've done the research, then the co-design, then you deliver within reach. Next slide, please. And I'll quickly talk to this, and Julia, come in please if you want to expand on anything there. We delivered all in all up to last month or so about 546 health checks, and out of that, a good fraction, if not 3/4 of that, 306 people were actually referred to GP practices. And we do know that outreach actually taps into people who don't normally actually access these services. So ideally, they should have all been seen by GP practice at some point within their needs assessments. But we managed to tap into this client group. But we were actually focusing on the pathway, the lipid and the FH program, where we do the health checks, and some of those medication are medication of choice within the pathway that we work on. So 87% utilization of our clinics when we offered those outreach sessions. The next slide, please. And again, this some of the learning, and you will hear some of the learning from our community leaders. So we're talking about engaging with community leaders, working with colleagues from a research perspective, but also looking at the options. We know we've got our colleagues from PocDoc on the call, using point-of-care testing, which is actually very fast, efficient within the communities, but engaging our academic settings as a place of actually testing, but also delivering those health checks within community centers, not the traditional medical model where you have to access a GP practice. Next slide, please. Yeah, if you can whiz through all those. This is just an example of some of the activities that we then delivered. So we had, as I've mentioned, bespoke outreach sessions where NUA Fitness or community centers held sessions. We had engagement with the Middlesbrough Football Club, where the health bus, that bus drove around. It's quite, in Middlesbrough, it's quite a recognized brand or a partner in delivering health, and it's actually not a traditional health partner, so it was quite helpful. But some of the most important resources which we produced were some of the comms information that was there, how the community leaders recorded their own videos, talking heads to share with communities, and just social marketing. I think the next slide will show a few more resources that we developed. So working with, not working against the NHS health check, we developed these resources where our partners, Middlesbrough Football Club, when they were actually going into delivery, we would use a standard clinical health check questionnaire, which then was quite useful, not just to collect the information and refer patients on, but it was the resource for them to sit back at home and read through and know the threshold. And that to us helped us to have that ownership of health, not just doing things to them, but actually them being partners in health. So the last, it could be the last slide. Yeah. So that's just the information that Julia and Marcus, if you want, we'll share them on the slide if you have any particular clinical or practical questions you've got. I think that's the end of that session. Yeah,
that was great. So I think one of the things I just wanted to highlight was the change in prescribing. So, you know, one of the slides there that you talked about, Joe, was related to ezetimibe and high intensity statin prescribing. For clinicians on the call, you'll recognise that those drugs have evidence that if you have cardiovascular risk and you are prescribed those drugs, then your risk of having a subsequent cardiovascular event is reduced. And you'll see that during the 1 year that the INHIP project was happening in Middlesbrough, there was over a 400% increase in prescribing of ezetimibe in Middlesbrough and a 53% increase in high-intensity statins. So we can't say that the project itself led to that, but certainly in the environment that the project was happening, there were dramatic increases in prescribing of drugs that we know reduce cardiovascular risk. And you would hope that some of the people in Middlesbrough, as a result, will have fewer cardiovascular events. And I would like to think that there is a relationship, may not be a direct one, but a relationship between this project and those outcomes. Brilliant. Well, thank you, Joe. So there's no questions in the chat at the moment, but what we're going to move to now is Joe's going to lead a conversation with Katrina Jackson, Idris Rashid, Binny and Shazia, who are community leaders. And Sarah Slater's also here from the NHS Health Check Service in Middlesbrough, from the team there. And I can also see that Lee's on the call from Middlesbrough Football Club Foundation. So a big shout out to the collaboration with them. They've done a huge amount of work with us, and it was an absolute treat to be there for the Stoke game in the car park at the Riverside. So again, you know, huge thanks for the support from them. So, Joe, do you want to start off with some of the questions that you want to ask the panel?
Yeah, welcome on board to the panel. I've always wanted to do this. I've watched BBC Question Time, and I wanted to be on the other side, just asking questions. So now is my chance. I'll start up with you, Katrina. And please, Sarah Slater, jump in from a commissioner perspective. We just wanted to know, as you are closer to the population that you actually do serve, what does this practical implementation of the Behavioural Insights Project actually mean to public health and your priorities to reduce health inequalities? So what does this give you, and what does this say to your ambitions and priorities?
Yeah, thanks, Joe. I'll go first, and Sarah can jump in if she would like to. Any sort of valuable research is hugely appreciated by public health, but in all the programs we have to address health inequalities. It's really important to us to get that insight into the barriers to any health initiatives, and obviously to the checks, and also the enablers and the motivators within our target communities, so that we can try and address them and increase uptake where possible, and learn from some of the findings. Well, I know we're not talking about a 3-year research project with hundreds of people involved, but it was very qualitative, and you're focusing on the target groups that we need to engage with where there is low uptake, i.e. our deprived communities and some of our ethnic communities that we know are hesitant to access the checks. Uptake is low in those most deprived communities, which basically just worsens the health inequalities that they're already facing. So the research was really valuable. Unfortunately, it did confirm some of our suspicions around barriers for our ethnic communities in accessing the checks. But the positive from that means that we have a bit more clarity around those issues. And it helps us moving forward in knowing that the issues that we need to address and share, so that we can share those findings with others, like our GPs, the people that we commission to deliver services. And it also helps us shape our public health messages a bit better as well to encourage uptake. So it's all sort of really valuable in addressing those issues.
Thank you. Is there anything you wanted to add to, Sarah, before I move on to the next question? No. Yeah, okay. Let me move on to another question for community leaders. Then I'll come back to you, Katrina. Yeah. And thanks, guys, Shazia, Idris, and Bini to come on call. And I have to say, a big thank you to Shazia, because I know you must have been out in the rain with your women-only group, really, who took part in this. So welcome on the panel. The first question, really, and it applies to all 3 community leaders here. I know some of the stuff is been covered in the video, which we'll share, but what are your own reflections in this INHIP project from a community's perspective? And what is the feedback from your communities around not just the impact, but what has happened throughout the project lifespan? Sorry.
I'll jump in first if that's okay, Joe. From the BME Network's perspective, we were involved from the onset in terms of the consultation sessions, but just looking specifically at the delivery of the project. We run a community radio station, so we've had sort of conversations about cardiovascular disease and sort of plant some seeds around that. And then we promoted the opportunities. And we have lots of sort of community WhatsApp groups, and we've got like a Facebook platform where we promoted the activities. And initially the uptake was a little bit slow, and then we tweaked our marketing in terms of putting a cost to the sessions as well, because we looked at online, and if you go to a private clinic, they're around about 149 up to £150. So we inserted, these are free, but if you go to a private clinic, they're up to £150. So we associate the value to that, and people then respond to that because they were thinking they were getting something worth £150 for free. So they were attending, wanted to attend the sessions. There was also messaging from sort of other community. So there's an element of exclusivity as well. So if we're looking at a particular mosque that we attended to where the sessions were delivered, so we said we're giving a priority to this particular mosque for X number of days to book the appointments. So they were community leader would say like he's had the session, the health heart check, and so they were looking up to someone that's already had it as well. And then there was an element of sort of reminders as well. So a lot of people would book things if they were like a week in advance, but they might forget. So we had an opportunity to send out like a WhatsApp broadcast to people that were booked in to get like a reminder on the day and maybe an hour before that the appointment was due. I think that Lee, who's probably is on the call, will maybe acknowledge that really did help in terms of getting people out on the day. So those are my sort of reflections for the day.
Thank you so much, Idris. Really quite powerful. And it came out through some of the narrative when we sat down with different communities. Same question to you, Bini. What's your reflection and any feedback from your communities?
Yes, my feedback, Bini Araya, I also based in Middlesbrough community worker. So I think it is 3 points that I would like to share. Number one, it is the leading up to the appointment. Conversations as community champions in the ground or on the ground, that you are almost energized to bring up a subject that is not properly talked about, and people asking you and challenging you, why heart? And that brings it right from almost nowhere to have a conversation, the importance of keeping your health healthy and having to check it. So it's a proper conversation, and it's almost like a privilege to have a conversation that is not quite normal in a daily conversations. So an element of leading up to the appointment, and how do you prioritize? Who do you invite? And why do you invite them? So conversations leading up to the appointment. And I think the second part is the convenience. And I'm sure Shazia will talk about it in her own time, because I have already seen the video, but it is the feeling comfortable at a location that you feel safe. So it makes it much easier to have that. And I think the third is, I don't think, and I think this goes to the foundation, I don't think many people get 45 minutes of anything from a GP, of anything, literally. I think that's a very generous time, and people felt, and from a particular culture, I'm trying to say a particular culture. In most cases, you have people say that, oh yeah, well, the GP have sent me out before I sat down.
So you're talking about the consultation time, isn't it?
Consultation time. They have never touched my body. I don't feel that I have been listened to. And that is directly linked when people language is, when English isn't their first language. So it takes time to process things. So the lesser time you have, no matter how accurate that session was with the GP, you feel a little bit unsure whether you have fully be able to explain. So I think that's a very generous time. And I think the last element is after the session, because it gives us the opportunity to say to people, okay, now you have finished, but can you engage in the gardening? Can you engage in other activities that we have availability? So it's a privilege to be able to almost, nail people down with the issue of a subject that is important to them or seen important to them, i.e. health check, heart check, and then offer them other activities that are good for their health. Do you know what I mean?
So that's really important, because in public we talk about social capital. So that's really good. That's really good. Thanks. Thank you. Shazia, any reflections from your side?
Yeah, similar to what these had said, giving the women an opportunity in a safe, modest environment where they felt comfortable to ask questions, because it was a female-only environment that they came into. And a lot of these women, I would say they were very hard to reach. a lot of them, you know, they didn't have the knowledge. And I think a lot of them, what we found, had lost faith. Like, you know, Binny said that a lot of them have lost faith because you're in and out the doctors, you're very lucky to get an appointment. So it was so nice to kind of see their bad experience and their bad, you know, the thoughts that they maybe had towards the NHS change and become more positive. That's been really, you know, a really good thing to see. And also the other point that Binny made about, you know, them understanding it. A lot of the time, like there was 2 or 3 women who came and said, we had a health check, but we walked away and we didn't understand it. We didn't realize. Now we've just realized this is actually what happened. Whereas this process, there was interpreters there, there was somebody there, and also that support. A lot of women came out of there with really poor results, and they were quite upset by it, but they had that like support system when they left the appointment of our staff members there to speak to them, signpost them, because I should have said this at the beginning, Noor Fitness, we offer fitness classes, cooking classes and so on. So they were in there already and they were kind of given, look, well, actually, you know, don't worry, this is what you can do. You can get involved in this. We've had women now going outdoor walking, and it's kind of created this environment where, you know, women who we have been trying to access for many years to come into the classes through this project have actually walked in to the classes. So it's been like a beneficial for all sides, really.
That's incredible. Could you remind us where you were going to go for a walk today? You were supposed to go for a walk, weren't you?
Well, we were meant to be going up Rosebery Topping today, but God said, no, you're staying at home today. We did go for a short walk, though, because we're trying to, like, explain to the women, because we live in the country where it's always going to be raining, so we are trying to change mindset. So we still did a short walk.
No, thank you. I'll come back to you guys with the 2 brief questions again. I'll just go back to Katrina. Very briefly, Katrina. So, can this learning, because we know with your strong public health background, you don't just look after CVD. Can this learning, can learning from this project actually be transferred to tackle health inequalities in other public health areas?
You're on mute, Katrina.
Just spotted that. I just realised I was on mute there. Sorry. I think some of the key principles that you found around, you know, tailoring approaches to make sure that language issues are addressed, cultural issues are addressed. It applies to all sorts of services that we offer, whether it's NHS health checks, whether it's cervical screening, whether it's, you know, some more basic stuff like physical activity and healthy eating advice. But the findings are valuable even in practical terms. I mean, we recently used some of the findings from this approach and the positives of the community checks to be successful in a community-based BP kiosks project, which will be starting shortly. Prior to this, we were considering offering just BP checks through our health champions, many of whom are on today, Idris and Binny and Shazzy are some of our great health champions. And that's another initiative that we feel will be successful because of the evidence from this approach, that people feel comfortable in an environment that's known to them, with people that they respect in their community, to have a basic BP check. And the underpinning theme of all that will be that through the BP and the BP checks in communities, we will be highlighting the importance and clarifying what an NHS full health check is and encouraging people to go to the GPs for that. I think learning from the research stresses the need for all health initiatives to encourage messages from trusted voices in community settings and the convenience around that. So there's lots of things we can build on there. And on a practical basis, we are actually due to recommission our full NHS checks in March 2025. So this is helping with our service spec on that as well. I know that you've shared some of the information that you've gathered with the PCN clinical directors, and you got some good feedback from that. Again, it'd be great for me moving forward to think that GPs themselves can consider some of the points that have been raised and think about their own approaches and perhaps encourage a more focused approach in the future. And again, it also helps with the research projects. Teesside University are currently looking at checks themselves across the whole of Tees Valley, and the information you've gathered will feed into that research as well. So it's all really valuable. It has sort of strengthened our thinking that community is the way to go, and that we learned a lot of that through the COVID approaches, and we've always felt very strongly about that. But again, the information you've gathered, the success of the community-based approach just helps us target our thinking even more and have the faith to sort of go down that route where possible. Yeah, So that's it's all positive for us guys. That the learning's always valuable, and like I say, also the building of relationships through the likes of the community groups they've engaged with. These will be the people and the relationships we will continue to engage with for future community-based initiatives, ideally, and it's forming that trust and those connections as well. So thank you.
No, thank you. And it's that collaboration, isn't it? Well, I've got one or two more questions. I know we need to leave time for the video at the end. We've got a video clip there. So back to the community leaders, very briefly, because I've got another question after this. So very briefly, in terms of sustainability, if such outreach services are to be mainstreamed, as Katrina is saying, what do you think needs to happen for it to be sustainable and for us to leave a lasting legacy? So anyone, Shazia, you could go first, please.
I think to kind of utilize resources like ourselves, like New Fitness, you know, we're a centre there. We've already got, you know, women coming in. So it's, you know, we've got the kind of expertise of, you know, trying to get the women to come in, motivate them to come in. So I think, you know, to do something like this, it just makes more sense to kind of work with organisations like ourselves and like Vinny and Idris, because we've already got a platform there working with, you know, the community already. So they have that trust issue, like, so they've got that trust with us.
Thank you. That's quite helpful. Bini?
Exactly the same. I think smaller community initiatives, because these are what I think they are. They are places of interest. So people go to a place, and then if you bring the checks into places that already people would go without having to make an extra effort because they have their own bad experiences or challenges to get there, I think it just makes everyone's life easier. However, I must admit, and I think Katrina is here, or the other commissioner, Sarah Slater, is here, the heating has to be paid for. The water bills has to be paid for. So when you commission, then these smaller initiatives, if you wanted to deliver, I think they would be very happy to deliver, as long as they are supported to carry on with, you know, opening hours, pay their staff. So nothing should be taken for granted or expected for people to deliver. So I think with the right support, and I think I would finally say that I think there is a really good value for partnership. I think what the bus have done with all their equipment and to bring it, you know, it would have been almost impossible for us to do what we needed to do without having the bus outside, and it just went so smoothly. You know, no effort from anyone, not too much headache. It just get on, and results are achieved. And I think the final point that I would make, Joe, is that people are tired of listening research. That university is coming, that one is writing, and then at the end of it, there is nothing for them. So it empowers community leaders who are answerable to their community members. Oh yeah, this is what you have said, and this is the result. People go with their health report. And I think, you know, something that is going to produce something is always a good start. And I think this is a good start, and sustain it.
Thank you, Bini. And the same to you, Idris. Before I go to the last question around challenges, please.
Just a brief point in relation to legacy. I think it is about partnership, but it's not. It's about doing building on relationships, and, you know, delivering services to the community is about building those relationships, and the partnership approach. And I think Katrina might add on this. There has been some discussions with some of the GP surgeries in terms of utilizing this model and taking services out to the community and bringing faith organizations and faith buildings and community hubs as a partner in terms of delivery, and not assuming that all health services need to be delivered in a GP surgery.
No, thank you very much. So the last one, the four of you, I'm just going to give you half a minute each. I know this is a challenge.
Well, not even half a minute, Joe. 10 seconds each. 10
seconds each, really. So if you to share, because we don't want to paint it all rosy to say it went well, what were the key challenges? You will just quickly share. So I'll start with you, Katrina.
Okay, my concern basically is ensuring that the records that we gather are transferred appropriately onto GP. systems, so that GPs are supportive of the approach, see the positives in it, and records are correct. And we know that person has a health check in the community, gets the outcomes, and then we track what they've done afterwards. That would be the ideal scenario. There's some data issues around that, but that would be the perfect challenge for me that we need to address.
Thank you. 29 seconds. That's still all right.
From our point of view, it's about sustainability. It's about, you know, you delivered something, you know it works. How do you continue and keep it going? Thank you.
Bini? Key challenge.
It is reading your long emails.
Okay, I'll try to be precise next time.
Yeah. Honest answer.
So I think the key challenge is to promise something and then be able to deliver, and then look at long term. We are tired, or I am tired of very, very short term. Something goes and then it finishes, it gets away. So I think, you know, long term is always a good idea from my point of view.
The NHS has got a long-term plan, so we'll work with you on that long-term. And Shazia, last but not least?
I would say from our end, more support, I suppose, like for resources and stuff from our end to be able to deliver things like this. Obviously with staffing and so on, we had to make a lot of changes to kind of like accommodate this. So I think from our end, that was probably the biggest challenge that we had.
Thank you so much. I'll pass back to Julia, because I'll be bothered if I don't.
No. Thanks everybody. We're just going to put the slides back up again, because it's just a video for 2 minutes that just captures some of the outputs from the project from the people that have been involved. So we'll play that through, and if you've got any questions, please put them in the chat. Go ahead, Abby.
Hi, my name is Idris Rashid. I'm the director of the BME network in Middlesbrough, and we've been involved with supporting the INHIP project from the onset. It's been great to be part of the project, and my reflection for the project has been really positive. I think we've achieved lots of positive things in terms of getting the community out and utilising the services. The work that has been delivered by the Middlesbrough Football Club Foundation has been fantastic, and I've had lots of positive feedback from individuals that have accessed the service.
It was a good success. We were able to have a lot of women from ethnic communities, a lot of wide age group come in and access and get their healthy heart checks done, which usually they wouldn't have maybe gone to GP and had it done. It was a very comfortable, safe environment for them to come.
I think the programme has made a huge impact on so many lives of the women that come to our centres.
I think it's great that we can take out the bus into the communities and then be able to utilise the service that's on offer. Lots of time people have struggled to access or get appointments, and being able to take the service to their doorsteps has been really positive.
My reflection on this has been that, you know, the women, they've had so much from this. You know, they've been able to come into a safe environment to get themselves checked out. They've been able to, you know, ask questions, feel confident, because they felt quite safe here. You know, they were in a trusted environment. And, you know, it kind of then became something that everybody kind of wanted to be a part of, which kind of, I think, was a huge success of this, that so many women wanted to come and actually get the health check. So someone would come with a friend, and then by the end of it, they were like, well, can we book an appointment in? Every time we put an advert out after that first video that we shared, it was just constant. As soon as I'd put an advert out, everybody would want to come in and book an appointment in.
What was good for it was there's a lot of ladies like myself who dressed in the Islamic dress code, and because this is a ladies only environment, everybody was comfortable to go and just put their sleeves up and get it done.
My colleague had it done straight away. I myself didn't access it after 4 weeks. I just have that fear about getting health checks and going to the GP. So when I did have it done, I was very grateful. I was told I had a very healthy heart. I was 5 years younger with my heart, so I was very happy, and I felt, oh, you know, that was good. So I felt positive.
And that kind of shows the power that if you can bring something like this in an environment that is convenient, safe, you know, easy to get to, with a language that you can understand, you will find that there will be a huge uptake of something like this, which obviously shows from the numbers that we got in.
Brilliant. Thank you. So I'm going to leave you with that. There's sort of 3 minutes left for questions, but we don't have any questions in the chat at the minute. So I'm probably not going to go to you as the audience for questions. Please do contact us if you've got anything more that you'd like to know about the project. The recording will be sent out to you, so you'll have time to digest certainly some of the results from the focus groups themselves. What I just wanted to say to finish off was to thank everybody who's participated today and participated in the project. I've worked in the NHS for 37 years now, and I have to say this has been the best project I've ever worked on in terms of seeing tangible outputs. And that's largely because of the engagement from the communities, from the collaboration with organisations like the Middlesbrough Football Club Foundation, etc. So it has been a real pleasure. One of the things that we were sort of advised at the very beginning when we went to the to a meeting in Middlesbrough that Idris hosted was that communities really didn't like it when people like us dropped in, did things to them and then went away again. And we are very committed to ensure that we're not going to do that. So, you know, you're not rid of us yet, Middlesbrough. We'll be back. And there are other projects that we're currently working our way through. So this is the beginning and most definitely not the end of this project. So we're exactly at 2 o'clock. I'm going to let you all continue on with your day, but just finish with a huge thanks to everybody for all of your time and for your commitment to the success of this project.
Just before you go, Julie, can I just pass on our thanks to Lee Harding as well and MFC Foundation team, because really positive feedback and lots of great work from Lee. So thank you to Lee and of course Jordan and yourself as well for involving us in the project.
No problem. Brilliant. We'll see you again soon. Thanks ever so much, everybody.
Everyone.